So it's my pleasure to introduce Dr. Mark Breazzano. Mark is a native of Syracuse. And he graduated cum laude from Hamilton College, where he received a senior prize in biochemistry and molecular biology. He then graduated magna cum laude from SUNY Upstate Medical Center with an AOA distinction. And after completing his internship at Yale, he completed an ophthalmology residency at Vanderbilt. And here he won the National First Place Residence Writers Award given by Ophthalmology Times in Vanderbilt's inaugural Lefkowitz Discovery Award. After finishing his residency, he completed his vitreoretinal surgery fellowship at Columbia. And during this time, he was recognized for the best clinical research paper, the Edward S. Harkness Eye Institute. Following fellowship, he was an assistant professor at Johns Hopkins Wilmer Eye Institute for 2 years. And at Wilmer, he conducted clinical trials and research with leading experts. In addition, he taught and mentored medical students, ophthalmology residents, and retina fellows, and was responsible for the retina education curriculum for residents. He's been on staff at the Retina Associates of Central New York for the last 3 years and is currently an assistant professor of clinical ophthalmology at SUNY Upstate. Dr. Breazzano has published over 100 peer-reviewed research articles, 9 book chapters, 2 white papers, has been involved in more than 70 media releases, 2 expert opinion papers, 8 review articles, and countless abstracts in the field. He's been invited to speak to multiple national and international audience of ophthalmologists and retina specialists. His contributions include demonstrating ophthalmology-specific occupational infection risk, as well as analyzing retinal screening practices for fungal bloodstream infections. He's on the editorial advisory board for Ophthalmology Times and is a peer reviewer for multiple journals. He's a member of the Retina Society to be inducted in September, I believe. Is that right? Congratulations. And the American Society of Retina Specialists. Please welcome Dr. Breazzano as he presents Fungal Endophthalmitis Screening. Where do we currently stand with the evidence?
Well, thank you so much for the warm introduction, Dave. It's really an honor to be here and really excited to share with you some of our work. And thanks for joining us today on a Friday afternoon. And yeah, it means a lot to be here. So yeah, so we'll be talking about fungal endophthalmitis screening.
Your screen.
Oh, absolutely. Thank you. Here we go. How does it look now? We're good there? Fantastic. So where do we currently stand with the evidence? So no financial relationships, and our key objectives here are primarily to look at this sort of discussion that's been happening between the Infectious Disease Society of America and the American Academy of Ophthalmology in terms of screening patients with fungal infections in the eye. And really to look at the recent evidence of current practices and how the epidemiology might have changed in patients with candidemia. And candidemia being patients with septicemia from Candida species. And then we'll try to apply evidence for and against the practice of routine screening in these patients. Where does this come from? So basically in 2016, the Infectious Disease Society of America released a clinical practice guideline that basically supported ophthalmologists routinely being consulted to examine every patient with candidemia, regardless of their clinical status, independent of symptoms, other aspects of their care, anything else that's happening, mortality, morbidity, how sick they are in the ICU, all of these factors didn't really seem to matter in terms of this strength of recommendation guideline. And it was puzzling to many of us in the field in ophthalmology because endophthalmitis, as we were seeing it, rarely, if ever, was detected in that setting, at least anecdotally. So part of the conundrum, I think, is illustrated with this question here. So this is from the ASRS Retina Image Bank. And I kind of want to open this up a little bit. This is part of the pimping that Dave asked me to do today. If anyone cares to throw out a number there, which of the 1 through 7 is from Canada? And don't be shy. 3? Great. Thank you. Any other guesses?
All 7.
All 7. Oh, I like that. Okay. 5. Okay, 5,
None of them.
3, 5, and none. Ooh, that's
And all.
and all, okay. It's actually 4. It's actually 4. So that was good, it's really close, that was great. Great job, yeah, so you can see a lot of them are white and fluffy. Why can't they be Candida? And in reality, a lot of these patients, even though 4 is technically the correct answer, there's no reason a Candida patient can't have 1, can't have 7, and can't have 3. So a lot of these patients often have multiple comorbidities to explain the findings in their retina, even if there is a white spot. So there's a few dilemmas with this. Not only is it non-specific, but we can kind of pigeonhole ourselves into a diagnosis of something being Candida when there is certainly an alternative explanation that could actually be more likely. And so that's the problem inherently with a screening paradigm that is not specific. And so it's challenging. There's no reason that 1, 4, 5, 7, or 1, 3, 4, and 7 particularly, or even other ones like thrombocytopenia, can't all have a similar finding and yet still be in a patient with candidemia. So even beyond chorioretinal findings, well, what about vitreous cells? Can endophthalmitis be nonspecific? And so similar type of story. 6 is probably a little bit more classic for Candida, but it doesn't change the diagnostic dilemma we're often in when it comes to vitritis as well. Vitreous cells can certainly be nonspecific too. Dehemoglobinized blood from vitreous hemorrhage, inflammatory cells, but certainly not an infectious process such as VKH, even virus versus bacterial versus lymphoma, something that's neither infectious nor inflammatory, but malignancy. These can all present with cells that can be challenging to distinguish from one another. So I think one of the most important papers on the entire topic actually comes from probably, this is about 20 years ago. This was a study that looked at patients just in the ICU and essentially seeing what retinal findings do they have. And 20% of them, 19%, regardless of candidemia, had abnormal retinal findings. And there were statistical analyses that were trying to tease out specifically which of the risk factors was more likely to explain the underlying finding. And in virtually all the cases, there was something besides candidemia to explain those findings. And so there was nothing really that specifically differentiated them. So if we get a candidemia consult, the vast majority of them are going to be in the ICU. How are we going to differentiate between those that's from Candida versus those that have something else going on as well? We know the mortality rate in candidemia patients is about 30%. And so they have other illnesses as well to explain it. So where did it really come from? Like, where did this IDSA guideline come from? Well, some of it is sort of, I shouldn't say the fault of ophthalmologists, but the limitations were even within our field. This is from the Blue Journal, Ophthalmology back in '82. And, there's a pretty alarming statistic here. 37% of patients with fungemia from Canada had endophthalmitis. And we can see this black and white photo. We clearly have a 3-dimensional whitish lesion coming out into the vitreous cavity. So this is clearly consistent with endophthalmitis. So of course, if we have it even that frequently, we would be very nervous about missing it. And we would do a quick tap and inject for that one. Yeah, okay. So, so then we go fast forward to 1994 and, a multi-center prospective study. This came out of North Carolina and Pittsburgh. It was about 3 different centers over 2.5 years, and about 120 patients. And this was based looking at Newson-Blatt criteria. So Newson-Blatt was a legend in uveitis at the NIH, basically had very stringent criteria that was followed. And for vitreous involvement to qualify as endophthalmitis, that was what was used. And based on that, not a single one actually qualified for Candida endophthalmitis. But notice some of these other findings or classifications. So we had non-specific lesions, nerve layer infarcts, these sort of aspects that were possibly, but not classically, Candida. And then you had probable, which was these whitish lesions, but not definitive. And so, obviously lax histopathology here. And so it's sort of wishy-washy once you're outside of the vitreous involvement as well. But really, just the not a single case, we kind of drove home that point. But we go back to 1982's paper, and there's actually a few articles like this, including starting from 1978. But we look at the actual definition used from this paper, and it calls for typical white fluffy retinal lesions, but there's no comment about the vitreous involvement. And then we look at one of the other pictures that was considered endophthalmitis, and we see this whitish lesion three-dimensionally that's behind the actual blood vessel. So at most it's chororetinitis, and it might even just be a cotton wool spot, which is not infectious and it is a non-specific lesion. So when we look through the rest of the literature, back in 2019, with our team here, we found that actual endophthalmitis rates were less than 1%. And this was based on a concordant definition of endophthalmitis. So those that required vitreous to be involved versus those that did not. And it actually correlated with the publication year. So that Donahue et al. Study that was multi-center prospective that stuck to the definition of vitreous involvement, the rates actually went way down after that because they were sticking more towards the definitions. And so it was less than 1% in these patients. And what was very interesting, there was over 7,000 patients that were screened, 1,000 of which were prospective. Not a single one of these cases actually had confirmation from the eye itself of any candida. So that was an AC tab, vitreous tab, vitrectomy specimen, microbiology, histopathology, none. It was all presumed based on systemic blood infection. And more importantly, there didn't appear to be any beneficial screening outcome. So identifying it didn't appear to actually change the management to the point where the outcomes visually were shown to be improved. And what do we mean by that? So when we look, this is a pretty busy flow chart, if you kind of bear with me on this. So at the very top, we start with our 7,400 patients that were identified from 38 studies. We go down the left side of the screen. So these are just 78 patients with chororetinitis and some kind of outcomes data. And those, they all had to receive immediate systemic antifungal treatment. So patients are only included if they followed the IDSA guidelines of having minimum 2-week systemic antifungals upon discovery of a fungal bloodstream infection and an immediate exchange of catheters if they specified it. 3 of them had chororetinitis threatening the macula. And among all those, there were no treatment failures, meaning visually impairing scar or blindness is the actual term they used, versus 47 that were successful. So that was regression of lesion and improvement of vision. Now, meanwhile, 19 died and 12 were lost to follow-up. And this is consistent with how we know the mortality rates are very high in these very sick patients. Now we go across to the right side of the screen, we got our 19 patients with presumed Candida endophthalmitis. And we call it presumed because none were confirmed to have any intraocular evidence. And interesting, one patient had just their catheter removed, the central venous catheter, because Candida loves to grow on plastic and other artificial lines. And they actually had their endophthalmitis resolved. I wouldn't advocate for that now. This was back in the late 70s that this happened. Okay, so now we move on to the 18 patients that still had their immediate systemic antifungal treatment. 12 of them just had that. They didn't have anything else done. 6 of them still died. 6 actually succeeded where it improved, and none of them failed. Again, this is loss of vision, blindness. The remaining 6 had additional invasive intervention on top of the antifungal treatment. None of them died. 3 were successful and 3 failed. And so when we take an association of this, we find that not only was there not a benefit to having additional invasive intervention, but it was actually associated with a poorer outcome. Now, there's 3 major limitations to this. The numbers are very small because clearly fungal endophthalmitis in this setting is very rare. And then also, of course, the disease extent, certainly could be highly variable, right? Endophthalmitis can be 0.5 cell in vitreous cavity versus huge vitreous abscesses. There's not really a great classification scheme that's been used for differentiating those. And then third, or lastly, these patients are not randomized. So there's clearly limitations to making saying that it's worse to intervene, but at the very least, there's no evidence to support that it's helpful. And, even in these, none of the three exhibited a fungal tissue conformation that may have actually benefited from the additional intervention. And there's no evidence to the contrary that they wouldn't have benefited anyway from more conservative management. So, so essentially, with endophthalmitis, there can be poor results regardless of invasive intervention or not. Although we should obviously be pursuing this when it's certainly clinically indicated. Just with a screening paradigm, we obviously want to be able to intervene with something that's going to guarantee a good outcome if we're going to be screening for it. And it was just interesting that there were no ophthalmic treatment failures, either with the chororetinitis or endophthalmitis groups. And consistent with the rest of the known literature, about a quarter to a third still died despite this. So then the question becomes, well, what about advances in systemic therapy? Can this still change our management? The real big question in the infectious disease world is that echinocandins have really come into play. And the thought is that it can't get into the vitreous as well. There's some experimental studies that suggest it just really doesn't penetrate. Well, the Spanish were actually ahead of us. Spain had a few different centers and they looked at what's called the candy pop study. I thought that was a great name for a study. I don't know how they came up with it. Anyway, so candy pop study though. So they looked at 3 different centers and it wasn't the most powered study, but there was at least 60 patients in this prospective investigation. And they found that there was actually no difference in eye findings between those that had echinocandins versus those that had amphotericin B followed by an azole. Which are some of the more traditional ones that we don't worry about getting into the eye, although they do have their own complications. And how does that make sense? Well, this is a great eye pathology paper. This is from Foos's lab from Los Angeles. And he basically showed, with this slide here, we have the H&E slide, the big red circle kind of shows the interchoroidal focus. So where we have inflammation breaking through Brooks membrane and RPE and then into the neurosensory retina. And then the inset shows a classic budding yeast from Canada itself. And really, when you have inflammation and involvement of the interchoroid, which is the most vascular tissue of the body, theoretically, you should be having adequate penetration of antimicrobial agents in that same area. So if the blood retinal barrier is broken down and you're already involving the most vascular area, does it really matter if it's getting into the vitreous or not? If you really want to be getting that underlying cause, which is the systemic infection itself. And so on OCT, we sort of see this too. The yellow arrow indicates, the interchoroidal focus where we do have presumably candidal involvement. Well, this was not a pathologically confirmed case, but it does appear to be breaking through into the outer retina where you would expect that medication to be penetrating. The other aspect to this too is, when we do identify cases presumably from Canada, we want to make sure it's Canada because some of what we give can actually make a problem worse. And so this is a great paper out of Emory that showed, fortunately, a less common problem of iatrogenic toxicity from amphotericin. The infrequency of injecting amphotericin into the eye leads a lot of people to be uncomfortable. And when it's so infrequent and it's outside the normal realm of when we give amphotericin, this is sort of a cautionary tale. We have, in the top corner there, you can see decreasing intensities of yellow there, which is what you want to see if you're going to inject this. But they reported 3 cases in what now is JAMA Ophthalmology. This is archives where it showed essentially panophthalmitis from the injection itself, along with retinal detachment, PVR, and fairly poor outcomes just from the medication. So, we obviously want to be careful about what we're injecting into the eye, and we want to intervene when it is appropriate and minimize opportunities to make the problem worse. And so fortunately, we were able to work with especially Flora Lum. She was incredible in helping kind of get this through, and the board of directors of the American Academy of Ophthalmology, where essentially came to the conclusion that it does appear to be a low value practice. When we looked at literature, the Canadians actually have a really good literature guideline in terms of evaluating what are low value practices and sort of allocating what we should be doing towards other efforts that are sort of depleting resources, not only from something that's not helpful, but may actually be leading to outcomes that are less favorable. We weren't the first ones to do this, though. The Royal College of Ophthalmologists, actually together with the Intensive Care Society in UK, actually did this during COVID before us. And we tried to reach out to the intensivists. They're like, sorry, that's your problem. No, so it's just ophthalmology. And IDSA, unfortunately, didn't want to really collaborate with us. So ended up, kind of reached out, but and so, okay, where is the real Candida albopicus? So this is an example of a case when I was a fellow. This was down at Bellevue Hospital in New York City, and this was a more sad case. This is an intravenous drug user with psychiatric issues who came in symptomatic, and you can clearly see vitreous abscesses on this fairly blurry phone captured image of the fundus. And so they ended up getting a tap and inject, not only antifungals, but antibiotics and even phosgarnet as well. Can't ever be too confident in your diagnosis till you know exactly what it is. And it did end up growing fungus. But despite quick intervention, it didn't guarantee a great outcome. And unfortunately, sad case, ended up detaching and redetaching under oil, poor visual outcome, light perception. And fungus was not grown in the blood. This is someone who came into the ER. This is typically how we find it. So one question we were trying to answer was, well, where is it? If we can't screen for it, where are these fungal cases? So as sort of the background on all of this, we know it's a fear diagnosis. We don't obviously want fungal albopicus. It's fortunately rare. There are poor visual outcomes. And the tissue conformation is challenging, as we sort of established. The differential diagnosis is broad, and we have this shotgun treatment approach. Did this case need phosgarnet? Probably not, but it was still a consideration because it was so severe in both eyes. We wanted to make sure that we didn't miss something. And of course, there's controversial screening paradigms as we've been reviewing here. This is another case that I had where this was actually a patient who did get antivirals and a lot of other medications before I saw them, and then eventually did improve just on systemic voriconazole. And this was, of course, a case of presumed but not confirmed fungal albopicus. The vitreous tap, the bloodstream, none of it came back positive, but we just have to call it presumed because it eventually did get better and there didn't seem to be a more likely explanation. So to analyze these cases, what we did was at Hopkins, we looked at what are the risk factors that increase fungal albopicus at the time of patient presentation, what are the prognostic factors at presentation, and are our screening guidelines valid? And had a really great resident, Aaron, who was lead author on this. I guess like Dr. Savage, unfortunately, I could not convince him to go into retina. So, but he, for some reason, went into glaucoma. I don't know. Yeah. So anyway, we found that there were 75 patients, 81 eyes receiving any intravitreal injection. And this was all 7 years worth of data. And basically broke it down into cases versus controls. And cases were those that were either confirmed fungal. So that was any type of microbiologic or histopathologic confirmation that it was fungus, or presumed, where there was no other diagnosis that seemed to be more likely, versus a masquerade. So that's basically anything else. Clinically similar disease in the long run. And so with these 81 eyes, of course, those that had prophylaxis antifungal injections were excluded. So these were trauma, open globe cases, corneal ulcers. Those are primarily ones that were excluded because those are a different etiology altogether. And then we have our 3 groups. We have our confirmed fungal, which were their 12 eyes, mixture of Candida, Aspergillus, and then hyphae, but otherwise non-specific. And then we had our presumed cases. And so, some of this could have a little bit of confirmation bias because they're immunosuppressed, had recent fungemia, had a biopsy, no fungemia, intravenous drug use. So some of this, the fact that we're calling it presumed fungal doesn't necessarily mean it still was fungal. It could have been sort of a self-fulfilling prophecy in the sense that, it doesn't mean that there wasn't still anything else that could have caused it. Regardless, we go then to the masquerades, and this was actually most of the eyes. So most of the eyes that received an antifungal injection didn't actually even have a fungus. And it was pretty much everything: virus, non-infectious uveitis, syphilis, choroidal metastasis. This was actually from esophageal cancer. And then most of them, though, were bacterial confirmed endophthalmitis ultimately, and then non-fungal infectious endophthalmitis. So could have been bacteria, could have been virus, not sure. And so besides the majority being different than fungus, there were features that did seem to make fungal endophthalmitis more likely than a masquerade. And so this is injecting in the ED or inpatient setting, having sepsis, an indwelling line, TPN, which is basically an indwelling line, cancer, immunocompromising conditions. And some of this, again, could still be that self-fulfilling prophecy that pushes us towards fungal, but still could have been something else. And then there were things that did make fungal a little bit more likely, and this is the delayed pain onset, slightly better vision, and delayed vision loss onset, which makes sense. Fungal tends to smolder along a little bit more than a bacteria does. And like many of our other studies, especially trauma, visual acuity at presentation correlated with a final visual outcome. But interestingly, none of the patients with fungal endophthalmitis were asymptomatic or identified by screening. And this is over 7 years at Hopkins, where they were very religious about getting these IDSA screening exams. So we did do a little bit of, after AJO, we did do a little bit of post-hoc analysis that we're working on. And so we're trying to figure out, well, is there an association between the timing, so the delay, any kind of delay between the antifungal treatment and the final diagnosis? And how about the visual acuity with the timing of the antifungal treatment? And what does this mean when it's actually incompatible with fungus, since so many of these were incompatible? And it actually appeared that masquerades were more likely than fungal cases to have the delays in intrafungal treatment, which is interesting since we would figure that the fungal cases ultimately might be delayed, because we would be more likely to treat with antibiotics. And what was interesting was the visual acuity is similar between the masquerades initially treated and those that were delayed. And similarly between the confirmed bacterial cases and other masqueraders. However, confirmed bacterial cases had similarly poor vision at the time of delay compared to when they were immediately treated with antifungal medication. So they could have been going along, and it seemed as if these bacterial cases were getting the antifungal because the vision became so poor. Well, we need to make sure. It was almost like a response, like, hey, it may not be bacterial, but really it's just probably other factors that are leading to that ultimate decision. And so really it's just challenging because the overlap in the presentation with other conditions can complicate its management. And it sort of strikes home that bacteria does still remain the predominant cause, even when fungal endophthalmitis is sort of suspected initially. And, obviously we need to figure out more about contributions as they relate to bacterial endophthalmitis and the visual outcomes. Of course, the different, factors, which I'm sure Dr. Wozniak can comment on with their microbial expertise, and the LPS and all these other aspects. Having a staph epidermidis inside your eye versus streptococcus is going to be much different. So those certainly play a factor here. But in terms of the timing, this can certainly raise issues with that. So has anything else changed? And so when we're starting our next systematic review, since it's been about 6 years now, there's been at least 10 studies now from all over the world, all different journals. And unfortunately, we still have the same issue, which is that there's been no confirmation from vitreous or ocular tissue that we've been able to identify. We still have the same problem. There's no control groups. The findings that we find in critically ill patients examined regardless of the candidemia. So those that have candidemia versus those that don't, the percentage of any retinal findings is still no different. You know, you go to the ICU and randomly screen any patient there, you're going to find some retinal abnormalities in about 15 to 20% of them. And the IDSA actually cites 16% in their own guidelines as a reason to not miss Candida endophthalmitis in a Candida patient. And you know, the screening rates are actually as low as 29% in these studies too. So we have that concern for selection bias, which we haven't really addressed before either. And so outcomes of treatment, when they're individually provided, they appear to resolve or improve just with systemic medication, and that's regardless of the agent, if the patient survived. And more recently, there has been less attention addressed with removing the central venous catheters, which we do know is essential. This is where the Candida, these fungal organisms, love to hide out, create biofilms, and are extremely challenging to eradicate unless we exchange and remove them. And so there were worsened outcomes in at least 2 cases with invasive intervention, similar to the older studies. And then I think there was a little bit of there's sort of maybe a little bit of tension between ophthalmology and ID on this. There is this gold standard that was sort of mentioned in the flagship journal, Clinical Infectious Diseases, describing this as a battlefield when we just want to talk. That's all, that's all we want to do. And yeah, so, you know, and they, instead of being less than 1%, they're saying it's 1.3%. Is that a big difference? You know, I don't know. That doesn't sound like it to me. And, you know, there's still no confirmation and there's still no mention about outcomes from the screening. So it's very interesting. It's very interesting. And so, and in this article, there was this burden of consultations that led to the academy position. And that was never mentioned in the position paper.
That's what they said, why ophthalmologists did it?
Yes, yes, yes. And, you know, I don't know if this might be recorded, that's fine. But there was actually a private communication from the leadership of IDSA. They said that ophthalmologists and retina specialists were too busy wanting to make money in an outpatient surgery center to come into the hospital and see them. And meanwhile, I looked up one of the head people on this, and he gets a very high salary from the University of Alabama outside of all consulting fees for antibiotics that he gets. And it's like, your salary is probably multiples higher than anyone here, but yeah. Okay, thank you for that comment. So yeah, so anyway, so yeah, and anyway, this burden of ophthalmology consultation was never mentioned in our paper. Strictly stuck to the data as best as we could. You know, defining this as a battlefield, you know, we're open to collaboration, and basically was turned down. Hopefully they'll come out soon and they say they're coming up with an update. So hopefully they'll involve us. And so the gold standard for prevalence of Candida endophthalmitis is how they characterize this last review. Again, there's no direct confirmation from the tissue, no outcomes. And you know, there's still a bias from failure to screen for criteria within each captured study. So you know, the IDSA systemic management has not been a focus of these studies when they do report data. And central venous catheter management has not even existed in any of the papers that I've seen in the last 6 or 7 years. So yeah, and you know, take home points, true endophthalmitis has been and continues to be exceedingly rare in this setting. Really our focus should be treating on underlying cause. So the candidemia itself and the associated comorbidities with prompt systemic antifungals and catheter exchange. The ophthalmologic screening intervention may actually lead to overdiagnosis, misdiagnosis, and even overtreatment or mistreatment. And so it's a little bit harder to quantify that because these cases are so rare and each case is so specific and unique. It's a little bit harder to quantify that, but it certainly does happen. And the current evidence does, however, suggest against indiscriminate screening. And really, we should be looking at the whole clinical picture. What are the symptoms? What are the verbal, you know, are they able to communicate? What's the prognosis? Do they have a palliative care consult in place? You know, a third of these patients are dying within 6 weeks. have there been delays in systemic antifungal treatment? So it's not that we should just be saying no, but is there thought behind these consults, right? If they, if their Canada culture came back 2 weeks ago and no one's done anything about it, like, all right, yeah, let's take a look. There could be something there and they clearly are having symptoms. Absolutely. But just a reflexive, oh, put an epic ophtho consult, just because the Canada's there, it just doesn't seem to make the most sense. So many conditions can mimic fungal osteomyelitis, but certain risk factors should raise its suspicion. And presenting vision, like many things we talked about, do correlate with vision. And there are many conditions that it can overlap with, infectious and non-infectious. And so this can delay and complicate management for endophthalmitis, fungal or not. And however, it's reassuring that none with fungal endophthalmitis are captured by screening, which does appear to support our current guidelines at the academy level. So I want to thank you all for listening and open to any questions. Yeah.
Great talk. Thank you so much. Just kind of coming back from ARVO, like in the infectious keratitis cornea world, there's a lot of interest in using AI and imaging.
Oh, sorry. I forgot I put this slide in. This was my co-resident. He was really inspired by our project. He's now a general ophthalmologist out in Seattle, back in his hometown. And yeah, so this was a quote picked up while training down in the South. Even a blind pig finds a truffle every now and then. It's kind of like us with a console bag going around the hospital.
That's what Neil Miller used to say.
Oh, really? Yeah. I guess it's Baltimore is still south of the major district line. Yeah, that's true. Sorry, what were you saying?
So I mean, in the infectious keratitis space, there's a lot of interest in using AI and imaging to try to figure out, when you have an ulcer, is it bacterial, fungal, whatever, can you distinguish? The tools aren't amazing yet, but I wonder if there's a role for, taking some of these fundus photos, training an AI system to, help figure out what is the real fungal endophthalmitis or not. I don't know if that's something that's going on.
Yeah, I think it's a wonderful idea. And yeah, I think it's been brought up in the last couple years, but the Retina Image Bank, it has a few images, but I do hope that, that would be a great project to spearhead, and I think it could be really helpful. Especially if we can get confirmation in the cases that we know the answer of what it is, and then we can get enough of a data set to have it learn. But yeah, I agree. That'd be wonderful. And
clinical micro evolves into more PCR, or sequencing based sort of diagnostics, that you'll get more answers. I think that's part of the conundrum, right? We send cultures and we never getting growth, or we have no idea.
Yeah. Absolutely. Yeah. Like with the PCR send outs, like we'll send a lot frequently to University of Washington, and now University of Michigan has the mid 88 they can send to as a PCR. Do you guys have in-house PCR that you do here, or does it send out also?
Yeah,
it's coming.
slow,
Yeah,
but yeah,
it's coming.
Some things, not all.
Yeah. Yeah, but it is an exciting time, especially the sensitivity on that. It's hard to beat for sure. And then, yeah.
At this institution, I found that the ID doctors are usually pretty good, but a lot of times what they mention is that the patient is, as with many ICU patient, is sedated, intubated, and doesn't have the capacity to describe symptomatology.
Yeah.
I'm just wondering where you stand on this data, whether that is an important clue to have in order to make the judgment call about whether to see the patient, or whether based on this data alone, no symptomology or not, it's likely going to be treated with systemic antifungals anyway, and so consult is less likely. And then I also wanted to add that this kind of speaks to a broader issue with ophthalmology screening for various things. And here at this institution, we get a lot of screenings for heart transplant evaluation for retinopathy, and I found anecdotally that to have very low yield as well, or people with CNS lymphoma asking for a vitritis screening to make sure there's no intraocular lymphoma as well. I was just wanting your thoughts on those as well.
Yeah, no, it's a great question. And the culture of every institution is also like very different on like what they want to screen for. For a while when I was a resident, like electrocution injury was screened for cataracts. Like that was the popular thing to do. Like God God help us if we find a cataract, so like that, so I understand like some of these just it's very reflexive and I think a lot of medicine has kind of gone down to a checklist type of situation in many situations, and the thought that we give our patients in many ways is not always present, and I think that kind of reflects it too, heart transplants, I mean, I think the intentions are right, but yeah, like, do we have evidence that that really improves outcomes for these heart transplant patients? I don't know. I haven't really done a deep dive myself, but my initial reaction would share your concern on that. And then your initial question about a sedated patient. There's a little bit of a difference of opinion on this. What I would do is I would actually put the question back at them. Is this patient giving consent for us to take a look into their eyes? And then based on what we see in there, would they consent to us doing interventions based on what we're seeing, knowing that they could be very much non-specific? If they're sedated and asleep and they don't even know that they're getting a tap and inject for something that might not even be fungal, let alone infectious, I don't know if I want anything done on my eye in that setting, especially if the systemic antifungals are going to take care of it to begin with, presuming it is even Candida or anything else. Because if they're sedated, there's probably something else going on. I mean, the other aspect of this too is, kids, I totally understand too. And thankfully it's a lot rarer with kids. And so I would speak obviously to our pediatric specialists here more so, but it doesn't seem like it necessarily is consistent there either. But, I think these are sort of case by case scenarios where, at least if you're thinking about it, I think that's, and not just reflexively saying no or just reflexively putting in the consult. I think that's really the goal here, is to just kind of minimize just the reflexivity of it all. If that makes sense.
A lot, thank you.
Yeah.
All right, well, thanks, Mark. Appreciate it.